So these are the most common types of lesions that we see when it comes to benign or even malignant lesions. So I think without further ado, let's begin with our first case. And I may call upon the students to help us with describing the histological images. I don't think that there is any need for anyone to feel intimidated. Just describe what you see, and then we will try to move from there. So this is from a 60-year-old female. There was an area of enhancement on MRI, and a biopsy was done. So here is a low power view of what the biopsy course showed. So obviously we are seeing here multiple ducts, which are all packed with some cellular proliferation. And there is fibrostroma in the background. And then there are some small cystically dilated ductal spaces. So Supriya, would you like to describe what you are seeing here in this image? Shakti, would you like to go ahead? Or Sneha, any one of you can pitch in. Just describe whatever you are
Sir, this
seeing.
one usual ductal hyperplasia.
Why do you say this is usual ductal hyperplasia?
Sir, there is a similar type of nearly similar type of cell nearly a similar type of hyperpigmented cell with lumina filled with lumen also.
Okay.
Yes,
So
sir.
how would that be different from DCIS?
Sir,
Okay, so anyway, you are right that this focus represents UDH or usual ductal hyperplasia. In Europe and United Kingdom, these kind of changes are also described as epitheliosis. So here what we see is a duct that is kind of filled with cellular proliferation. These cells are kind of haphazard, right? I mean, there
yes,
is
sir.
some overlapping, the spacing is not uniform, the cells pretty much, are not respecting one another. Similarly, here another duct is also showing changes of UDH. So here now you are also seeing some spaces, luminal spaces, which are sort of fenestrations rather than punched out spaces. Some of these are kind of compressed, some are more open. And then we have a similar cellular proliferation, which is not really very orderly. And as you can notice here, most of these spaces are peripherally pushed. They are not so much in the center. So yeah, the diagnosis here is usual ductal hyperplasia. And if you have any difficulty, you can always use, and certainly in United States, we do use immunohistochemical aids in supporting our diagnosis in difficult cases. So this case is not that difficult, but as a teaching point, I'm showing you the use of a stain called CK56, which will show like, some sort of a mosaic kind of staining pattern with CK56, which is typical of usual ductal hyperplasia. This kind of staining will be absent in most instances of ADH or atypical ductal hyperplasia or even low-grade DCIS. A similar stain, which is actually a cocktail of various antibodies, low and high molecular weight keratins, as well as myoepithelial marker P63 is used here. And you see here that the brown staining cells correspond to the staining with CK56, and the pinker stain is the low molecular weight cytokeratin. And here on the periphery, you have the myoepithelial layer. So again, any of these stains can be used as an aid to diagnosis. But I think we have to really go by our morphologic impression before ordering the stains. So again, to summarize what we saw, here is another focus of usual ductal hyperplasia, where we see jumbled up cells, some of them overlapping of nuclei. These cells are bland, appearing with vesicular nucleus, small nucleoli. And in fact, some of these nuclei actually show nuclear inclusions. And some of these also show nuclear grooves, these linear grooves. And again, this arrow will now point out the nuclear inclusions. Now, sometimes you may actually see a rare mitotic figure, as is seen here, pointed by the yellow arrow. So the presence of rare mitotic figures does not take away from the diagnosis of usual ductal hyperplasia. You have to go really by the overall morphologic appearance. And once in a while, you may actually, especially in those cases where there is florid hyperplasia, you may see necrosis associated with it. Now, we know that necrosis is typically associated with DCIS, but you may get that also with usual ductal hyperplasia. So merely the presence of necrosis should not make you diagnose something as DCIS. So what is the differential diagnosis of hyperplastic intraductal lesion? We already saw at some length the morphologic appearance of usual ductal hyperplasia. Now, at the very low grade cytologic end of the spectrum of neoplastic ductal proliferations comes atypical ductal hyperplasia. Now, this is very different, right? Morphologically, these are very uniform looking cells. So that is an important feature in contrast to UDH, where the cells appear very different from one another. And also the spaces that you see in ADH, or for that matter in DCIS, are kind of, this kind of punched out spaces. So that is described also as a sieve-like appearance, unlike these fenestrations in UDH. Now, DCIS, of course, is further progression of ADH, and we will talk a little bit more about that and what the problems are in distinguishing ADH versus DCIS. And some of these problems are really very difficult to resolve. And that actually can be sometimes problematic, both clinically and also in terms of making a diagnosis. But anyway, so at the extreme end of this intraductal proliferation, of course, is DCIS. And this slide that we see here actually is a high-grade DCIS with a lot of necrosis. So again, DCIS may be low-grade, intermediate grade, and high-grade. Now, again, ADH can have different morphology. ADH and DCIS, they don't necessarily have to stick to only one morphologic pattern that we saw in the previous slide. Sometimes you can get this kind of micropapillary proliferations, tufts of cells pushing into the lumen. And typically in ADH, again, the hallmark, of course, for both DCIS and ADH is the uniformity of the cells. And these projections in ADH or DCIS, they tend to be elongated and smooth like this, unlike in UDH, where again you can sometimes get micropapillary type of pattern, but these tend to be different from what we see here. They tend to be more kind of, angulated or irregular, and you will often see darker nuclei within the tuft. And then this is because, some of these cells, they tend to undergo maturation, which does not happen actually in neoplastic ductal proliferation. So that is an important point to remember. If you see maturation of cells, some cells towards the luminal aspect uh, becoming darker and flatter than the one at the basal portions of the ductal epithelium. So that is, an indicator of perhaps we are dealing with a benign intraductal proliferation. Now, this is just to show you a schematic diagram of the progression of intraductal proliferations. So this is not really very accurate, but I think this helps us to understand how the life history of intraductal proliferation plays out. So here, for example, is a normal duct. And when the proliferation is benign, uh, the cells will multi-layer and perhaps eventually fill up the duct, as we saw in our example of UDH. And a similar kind of process also happens in ADH and DCIS. But the difference, of course, is that the cells here are uniform and they tend to respect one another's boundaries. Now, of course, if this continues to progress, then you will have invasion into the stroma, and that is how invasive carcinoma arises. Now, it's important to remember that this kind of scheme that I am showing you here is only good for the low-grade pathway. So it would be like, ADH, low-grade DCIS, and then luminal type of invasive carcinoma or well-differentiated invasive carcinomas. This does not necessarily illustrate what happens at the high-grade end. So I think that's something important to remember when it comes to the life history of ductal lesions in breast. Now, just as we saw in that diagram, I'm just trying to show you how it translates to our glass slides. So here is a duct which is probably primed to proliferate, and you can see proliferative changes already beginning, and then it has progressed to become what ultimately may fill up the entire duct, even in examples of usual ductal hyperplasia. And similar type of progression will happen in the low-grade pathway. So here we are seeing somewhat flat kind of atypical epithelial cells in, this is sort of flat kind of epithelial atypia, if you like. So this is the earliest type of change that is happening at molecular level and is now seen morphologically as atypical cells. And eventually, these cells will try to proliferate and they will push themselves into the lumen. And then, given sufficient time, they will eventually populate the entire duct to give us ADH. And of course, the picture of ADH can be very different from one instance to another. Sometimes it may become solid, sometimes micropapillary, sometimes cribriform, and so on. So here, for example, this is now our cribriform. Now, DCIS as such, by definition, cytologically is not very different from ADH. So that's, I think, important to remember that the way we distinguish low-grade DCIS from atypical ductal hyperplasia is more by quantitation. So if there is more of ducts involved, and in your estimation, this is now beyond what would be reasonable to accept as ADH, then you know that such a type of lesion will qualify for the diagnosis of low-grade DCIS. Now, obviously, this opens itself up to inter-observer differences, right? So some people may have a certain threshold to call something as DCIS, and others may have a spectrum which will allow, their own index may actually uh, allow them to call something only as ADH. So there can be two persons interpreting something differently. One will call something as ADH and the other may call the same thing as DCIS. So there is no easy way out of this, and we will look into this a little bit more as we talk further on this subject. But this obviously has great clinical significance. How a particular case is managed may dramatically become different based on how you diagnose these kinds of lesions. So it's important to try to tighten up our criteria. And some of this only comes with experience, unfortunately. So again, low-grade DCIS, low-grade DCIS, higher grade DCIS, the cytologic atypia will be very different. These nuclei will become larger, they will become more hyperchromatic, there will be variations in the size. Oftentimes you will see necrosis with high-grade DCI. So this is a different animal altogether. And how this is managed is also very different from how low-grade DCIS is managed. So the progression pathway, and I think I alluded to this earlier, but the progression pathway that we described earlier, this mostly applies to low grade, that sequential kind of progression only applies to low grade. It's not applicable to high grade DCIS. The life history of this is so rapid that you are unlikely to actually see the progression. In fact, in higher grade lesions, you may not even see DCIS. The first encounter for this kind of lesion may be in the form of invasive carcinoma. So again, even after working in pathology and in breast pathology now for so many years, my career began actually in 1982. So it's, now I have worked in the field of pathology for 40 years, and a lot of time of this has been in breast pathology. And then in spite of all that, I still have this recurrent question. Is this UDH? Is this ADH? Or is this DCIS? So I don't want to discourage you, but uh, we always learn something every day. So we have to always remain open to newer ideas, and we always learn from others. So we should be open to discuss our problem cases with our colleagues and our peers. That is how we learn. Because our goal is actually to do good service to a patient, not so much to do with our ego or our, sort of self-value or whatever. So anyway, so here is a case where, is this going to be DCIS? Is this going to be UDH? The spaces are not punched out. I see some overcrowding of cells, but these look kind of neoplastic to me cytologically. So in these cases, what you do is you show it around, right? You show it to your colleagues, and then you do stains. Your CK56, if this was UDH, you would have expected most of these cells to stain brown. Here, there are only rare brown staining cells, which are probably residual ductal cells which have been pushed around by these neoplastic cells. So this is a neoplastic proliferation based on cytologic appearance and on CK56 staining. Now, just a couple of weeks ago, a case was sent to me in consultation by an outside pathologist who had actually made a diagnosis of DCIS in this particular case. So this is a particularly florid looking ductal proliferation, absolutely expanded ducts which are filled with ductal proliferation. But as you can see here, this is the type of picture we saw in UDH, right? So the pathologist who saw this probably is not very familiar with breast lesions and was probably taken in by the florid nature of this lesion and by the presence of necrosis, and made a diagnosis of DCIS. Luckily, the case came to us. And of course, since we see these types of lesions pretty much every day, for us, this was not such a difficult problem to resolve. Uh, so, you see this kind of darker nuclei here. I was talking to you about maturation. So these cells are very different, right? So you don't expect to see this heterogeneous kind of cell population in DCIS. So regardless of the presence of necrosis, a case like this is really a florid UDH. So I think I'm glad that the case came to us, because otherwise this patient would have been treated like this with a diagnosis of DCIS, and would not only would have undergone a different kind of surgery, but heavens forbid, may also have got radiation, which obviously she absolutely did not require, not to mention the ill effects of radiation to a patient. Now, I think this is a problem. This is not a new problem, whether something is DCIS, UDH, ADH. I mean, this has been going on and on forever. And Dr. Rosai, many years ago, Dr. Rosai was a chairman in our department when this study was published. He did this interesting study, which was published in the American Journal of Surgical Pathology in 1991. What he did was he sent these 10 cases to 5 pathologists. Now, these 5 pathologists were leaders in breast pathology at the time. So this is not like you and me who got these slides to review. These were who's who in breast pathologists at the time, who got these 10 cases. And they were asked to classify based on the appearance on an individual slide. So AH stands for atypical hyperplasia, CIS stands for carcinoma in situ, and then, some of these were ALH, which stands for atypical lobular hyperplasia, and then H stands for hyperplasia or benign or UDH. Okay, so H in our case is going to stand for usual ductal hyperplasia, AH will stand for atypical ductal hyperplasia, and CIS will stand for DCIS. And look here what is happening, There were cases, for example, the ones that are highlighted by these red stars, where pathologist A and C thought that it was DCIS, but there was a D pathologist who thought, and also E, who thought that this was benign hyperplasia or UDH. So when you look at all these cases, these leaders in pathologists, they did not agree in many of these cases. And honestly speaking, not much has changed since then. We are still grappling with this problem of whether something is UDH, ADH, or DCIS. I mean, in our consensus conference within our department, it's not unusual for us to bring for review by our peers about what exactly a particular case represents. And I think this is very important because ultimately, a diagnosis may determine how a patient is going to be treated. So it's not a small matter. So that brings us to this question, after all, why is there so much inter-observer variability? I mean, why aren't we able to get around this problem? So in the next few slides, I'll try to delve into this. And of course, why do errors happen? We just saw, right? A pathologist sent me a case where he had diagnosed something as DCIS and with which I did not agree. Now, obviously, the first and foremost is that we all have different set of eyes, right? And therefore, we have different thresholds for atypia. Something that looks atypical to me may not look atypical to you. And so, I mean, obviously, we then have to go by what the majority. So it's not a very, a very nice way of resolving this, but, ultimately you have to go by what everybody else thinks, right? So you show it around, you show it to more experienced people, and hopefully their threshold for atypia is more accurate than ours. So I think this is an important problem, which leads to different diagnoses on the same slide. Sometimes it is simply lack of experience. We all begin at a different level, right? In 1983, I was a greenhorn. I hadn't seen anything. So anything that somebody would have shown to me as DCIS, that was the only thing that I saw, right? So I would not be able to then read into something which is beyond my repertoire. So there are two lesions. Both look kind of alike, somewhat alike. They look papillary, they look hyperplastic. So one of these is malignant and one is benign. But if you haven't seen these types of lesions, you may either call both of them malignant or both of them benign. So, but if you have seen something like this previously, then you will know how to address this problem. So I'm just showing you a higher power. This is lesion A and this is lesion B. So if you look at the lesion B more closely, you will now begin to see that there is some mucin production within it. That is kind of unusual for benign ductal proliferation. It may rarely happen. Nothing is impossible, but it's unusual. So now, your antenna are going up. Oh, what the hell is this? So if you had seen something like this, you would right away know at first glance that that lesion B is actually a neuroendocrine DCIS. Now, having suspected that, you would order appropriate stains, as was done in this case. So the lesion stained with chromogranin and synaptophysin. Both of these are neuroendocrine markers, and therefore you would then render a diagnosis of DCIS with neuroendocrine features. Admittedly, these types of lesions, they are low grade. They occur in older women, most of the times in their 70s and so on. And since they are indolent, even if you call something like this as benign, probably the patient may not suffer that much because hopefully, it may not progress in short order. But of course, that is not to say that you should not make the correct diagnosis. You always want to make a correct diagnosis and have this patient treated appropriately. Now, sometimes, some benign things may mimic actually DCIS. So here, for example, is collagenous ferrulosis, which will, superficially look like punched out spaces, cribriform type of spaces. And if your basis of diagnosis is cribriform type of spaces for the diagnosis of DCIS, then you will make a diagnosis of DCIS disregarding the other features that you should be looking for in arriving at a diagnosis. Now, when you look at these areas of, spaces within this collagenous, you will notice that this is not like a punched out space. There is actually some material here. This is the collagenous material. This is the basement membrane material, which is secreted by the myoepithelial cells. So the myoepithelial cells play a role actually in the production of this kind of cribriform, sort of pseudo-cribriform appearance. So at some point, this may not have been empty space at all. It would have been like pink material, basement material, and that has undergone liquefaction, and then this is actually an artifact of our processing, which leads to this kind of space-like appearance within this lesional change. So collagenous spherulosis is often like a mimicker. And in early days, you may make a wrong diagnosis. But I think it's important to look at the entire picture and not jump and catch one feature in making a diagnosis. So here is to compare collagenous spherulosis with cribriform DCIS. You can see that some of these cells which are lining these cribriform spaces actually show polarity, right? So there is like a luminal border of these columnar cuboidal cells. So this is an important feature of DCIS actually. And that will not be present in collagenous spherulosis. Not to mention that these are neoplastic cells, whereas these are not. So that is something you have to be looking for, not merely the architecture. So now this brings us to the question about, is there a size criteria to distinguish ADH and DCIS? Because, you know, the way ADH is managed is quite different from how DCIS is managed. In our setting, if you make a diagnosis of ADH, the patient will get an excision or a lumpectomy. And that pretty much is the end of the story. Now, many of these patients will be offered hormonal treatment as a preventative measure, but many of the patients may even decline to go on tamoxifen or similar agents. On the other hand, DCIS will not only get a surgical excision, depending on the extent of DCIS, some of these patients may actually undergo mastectomy, and some patients may actually elect to get a mastectomy if they have, a higher risk with some germline mutations or strong family history and so on. But in addition to getting a surgical excision in the form of lumpectomy, many of these patients with DCIS will be offered and will perhaps get actually radiation therapy, which is, not a small thing. So we have to be very careful in how we diagnose ADH and DCIS. And over the years, what I have seen happening in United States is that because lesions are detected earlier and earlier in their life history, uh, at the low grade end of the spectrum, uh, there is some sort of reluctance to call something as DCIS because you want to manage these patients conservatively. Now, the question of size criteria was first addressed by David Page and also Tavasoli. David Page was a Duke in Tennessee, and Tavasoli worked at Yale in New Haven, Connecticut. So both of these breast pathologists, they did studies on elucidating atypical hyperplastic lesions in the breast. And what Page concluded was that if more than two ducts were involved by atypical proliferation, or if the span of such lesional changes exceeded 2 millimeters, then such a lesion would represent DCIS. If it was lesser than that, then that would qualify as ADH. But you have to remember that this study was actually published in 1985. So this is from an old cohort, right? So things were different. The way lesions were detected were very different back then versus what is being done now. So we should be looking forward to studies based on more recent cohorts to find out what eventually happens to these patients carrying the diagnosis of ADH versus DCIS. So I, for one, don't necessarily go strictly by these kinds of rules. But to make the point, if you have an atypical ductal proliferation as is seen here, which is now spanning 6 millimeter, I think it would be fair to make a diagnosis of low-grade DCIS. Again, you have to remember that all this only applies to low-grade lesions, not to the high-grade lesions. On the other hand, if the lesion is small, less than 2 millimeters, then that, although they may look cytologically similar, a diagnosis of ADH would be a fair diagnosis for that kind of scenario. So this is a useful rule. It may be used as a general guide, but this rule is not necessarily a standalone, at least in my experience. Now, this may even be problematic when you are dealing with core biopsies, because how are you going to measure the size of atypical ductal proliferation in this kind of material, right? I mean, there is one core here with maybe one or two ducts involved, one here. Now, in the real breast, the span of something like this could be more than 2 milli, but there is no saying with any certainty. So, you may end up calling something like this as ADH, cannot rule out DCIS, DCIS, minute focus, or you could call something like this as ADH alone, would also call this as ADH, bordering on DCIS. So you can use various kinds of descriptions for such encounters. It may not matter that much because even with a little bit of atypia, the surgeon will get excision, and then the final diagnosis of DCIS versus ADH would be based on how the surgical specimen pans out.
Excuse me, sir.
Yes.
Sir, there's a request to use pointers for the pictures, please.
Okay. So I was just, yeah, I don't know. I'm not getting the.
You can click on the right side of your mouse. You'll get a pointer options. You can select the laser pointer. If you click the right side of your mouse or maybe two fingers,
Okay, got it.
you get an option of
Okay, so
laser
here,
pointer.
yeah,
Yeah,
okay,
perfect.
so got it. Okay, here it is. So this is a core biopsy which is showing atypical ductal and you can see that this is another core showing similar change. Now, how do you measure the size here, right? So on core biopsies, unless you have like a core with many ducts, atypical ducts lined up and involving, in that case, you could measure, but here you can't measure. This could be more than 2 millimeters, less than 2 millimeters. So you would end up calling something like this in a different ways, right? ADH cannot rule out DCIS. Some may even call it DCIS, depending on their index for atypia. What I was saying was that it doesn't matter that much in core biopsies because once you call something as atypical, the patient will undergo excision and then the final assessment will be based on the excision specimen where you will be able to better see the span of atypical ductal proliferation and measurements may be more reliable. Now, of course, the nuclear grade is an important discriminant in distinction. All bets are off if something is high grade. For example, here, right? I mean, this is low grade, so you could quarrel, right, with others whether it is ADH, DCI. But here, when it is high grade, right? I mean, you don't even one duct is enough to call something as DCIS. So this is something important to remember. And then, what is also important to remember is that whenever you have encounters with ductal proliferations in core biopsies, you have to be very well informed about the patient, about what kind of imaging studies have been done, what is the family history, what is the age, and so on and so forth. So for example, in a case like this is a very tiny focus which is showing perhaps, low grade kind of atypia. It's only measuring 0.5 millimeter. Now, I should not rush myself into diagnosing something like this as ADH on a core biopsy I should first ask myself, is this representative of what the radiologist saw? So if the radiologist is now describing multiple foci of calcifications, and many of those were removed in the core biopsy specimen, and I'm only seeing a little bit of calcification, my next step is not to make a diagnosis. My next step is to actually look at deeper levels of the tissue, because sometimes, when a tissue plane is only superficially cut, you may only get part of the picture. As you go deeper into the block, much more may pan out, and your diagnosis will then be more accurate than it would be when you are looking only at one portrait on the slide, right? So I think this is something which is not emphasized enough and should never be overlooked. Before you render any diagnosis on any biopsy, not alone breast biopsy, you have to be very well informed about the patient. If you don't do that, then you are opening yourself into making errors. I cannot emphasize this point enough. You have to do your due diligence. Otherwise, you are engaging in malpractice. And I think another important thing that we have to remember is a point that was made by a giant in pathology, and also one of the giants in breast pathology, Dr. Ezopardi from United Kingdom. He published in his very nice book on breast lesions. He said that when you are looking at hyperplastic ductal lesion, look at the company they keep. Now, this is an important thing to remember. When something overall looks benign and you have a focus which looks like kind of funny, don't rush and make a diagnosis of DCIS. It's most likely benign because it's keeping company of benign changes. If you are in good company, you are probably good, right? If you are in bad company, you probably are bad. So I think that is a good observation that he make, and that comes in handy sometimes in situations which are otherwise kind of difficult to resolve because of some artifacts and all, or some unusual kind of appearance. So here, there is crushing artifact, and I have here some lesional changes going on. This whole thing is one unit, by the way. So I'm not going to rush into making diagnosis by looking at something which is really, it's not really optimal morphologically. I'm going to look at the rest of it. And the rest of it looks to me like benign, right? It's just UDH. So it's probably UDH, So it's probably safer for me to err on the side of benign in such a situation than calling something totally out of place malignant lesion. Now, of course, you must keep yourself open to using immunohistochemistry in resolving these types of problems. And the common stains used currently in our practice is keratin CK56, multiplex stains like ADH5, and also ER can sometimes help, and we'll see how it can. And you use myoepithelial markers to rule out invasion, early invasion, and so on. But I think, again, with the use of these stains, you have to also be aware of pitfalls. So here is an example of UDH. Now, this may look somewhat funny on cytology, but when you do the stain, you will see this nice mosaic kind of staining pattern with CK56. All these brown staining cells, they are crowding in the center. I was talking to you about maturation. So the CK56 cells stain, the keratins actually are expressed more as basal markers, which are more towards the basal layer. And that is how the maturation happens towards myoepithelial lineage. So this kind of appearance helps you in making a diagnosis of a benign proliferation. On the other hand, when the proliferating cells lack CK5-6 staining, then that is probably an atypical proliferation. Now, sometimes you can get some brown staining cells, but these are the native resident cells within the duct which have been pushed around. So you have to be aware that sometimes you may see some brown. You have to look at this pattern of staining rather than mere presence of some brown staining cells. Now, sometimes, these darker looking cells may appear at the luminal aspect of a ductal proliferation, and you might think, oh my God, because these are dark, this is maturation, and therefore this may be usual ductal hyperplasia. But, funny, that sometimes these darker looking cells may be similar to these, but they just appear different. They are like a pseudo maturating kind of cells. If you do stains, they will have the same tinctorial properties as the other neoplastic cells. So here is an example of a very particularly florid ductal proliferation, right? So what is this? Is this DCIS, ADH, UDH? If you can't make up your mind and your friends say that, okay, order stains, and you order stains, and then there you have, right? I mean, your CK5-6 solves the problem for you. Most of these cells are staining with CK5-6, and ER actually, in low-grade lesions, you would expect ER to be uniformly positive in most of the neoplastic cells. So here that is absent. So this picture based both on CK5-6 and ER helps you to make the diagnosis of usual ductal hyperplasia. This is just to show you what you would expect in terms of ER staining in low-grade DCIS. Pretty much all the cells will be positive with ER, unlike here where, this is not like a uniform population of cells. And therefore, only a minority of the cells are staining with ER. Again, there is no point in using CK5-6 when you are dealing with high-grade lesions. If you see a high-grade lesion, please do not order CK5-6 because, as we all know, some of the DCIS may be basal-like in terms of its genotype. So the basal-like DCIS will show the basal markers, which is happening here. The tumor cells themselves are expressing high molecular weight keratins. So what we have to remember from these illustrations is that the use of CK5-6 should be restricted to the low-grade lesions and not to the high-grade lesion. The diagnosis of high-grade lesion is morphologic and morphologic alone. Now, when it comes to use of immunohistochemistry, it's important to order the correct stain. Now, this also comes with experience. Here is a case that I saw in consultation a few years ago where the diagnosis rendered by the outside diagnosis was ADH for something like this, because these are monomorphic looking cells, solidly occupying ductal spaces. They do look monomorphic. So obviously, it would be reasonable to think that this might be ADH or even DCIS. But I think, unless you ask the right question, you will order the wrong stains. Now, in this case, right off the bat, when I saw this, I kind of suspected that this might be LCIS rather than a ductal proliferation. So the outside pathologist, of course, had ordered CK5-6, thinking that this is ductal proliferation. And the question he had in his mind was whether this is ADH or UDH, right? So he ordered CK5-6, and the CK5-6 is negative. So the diagnosis, therefore, made by him was ADH. But really, it was LCIS. And for that, you had to order not CK5-6, but you had to order the appropriate stain, like ecadherin and P120. And as you can see here, that our lesional cells are showing cytoplasmic staining with P120. In this case, although I'm not showing you the slide here, there was absence of staining with E-cadherin. So that allowed me to make the accurate diagnosis of LCIS in this case. So again, this can be very important in how a patient is managed. So accurate diagnosis, it's not only a question of whether it is UDH or ADH. Sometimes it's also the phenotype that may actually guide a surgeon's hand or how an oncologist is going to manage a patient. And we also have to remember that some of the cell types that are involved in ductal proliferations are innately non-expressors of CK5-6, like the apocrine cells. So this is a totally benign apocrine metaplasia. So there is no point in doing CK5-6. If you do CK5-6 and you are going to base your diagnosis on that, then you will make a diagnosis of ADH for absolutely no reason. Now, these apocrine changes can sometimes be quite puzzling, They can be quite proliferative even when they are benign. And they can throw various architectural kind of patterns, papillary and cribriform and so on, micropapillary and all, and yet they may be benign, but it may be difficult in some unusual instances, as we will see. So for example, here, this is like an apocrine cystic papillary apocrine hyperplasia. Now this, to a beginner, may actually look like some kind of a atypical proliferative lesion. Unfortunately, sometimes the apocrine cells can look quite nasty, with large nucleoli, even when they are benign. And as you can see here, in these two slides, one of them, this is benign apocrine hyperplasia, and this is like DCIS. Now, this can be really problematic, even for experienced pathologists to make that distinction when it comes to apocrine lesion. Is this benign or is this malignant? And this can be so challenging that sometimes, you may kind of be on the side of caution in your core biopsy encounters, and you may suggest some atypia so that at least the lesional area is excised, and then you are in a position to make a better diagnosis. So is there any way of getting around the dilemma of apocrine lesions? So Peter Rosen, who also was a breast pathologist at Memorial Hospitals several years ago, he had studied this topic in some greater detail, and he had provided some tips for resolution of apocrine lesions. So one of the things he said that when they are atypical or malignant, the apocrine cells, they show vacuolation. So there will be a lot of cytoplasm which will be vacuolated. He also said that when you see nuclear smudging and marked isonucleosis and presence of necrosis in the apocrine setting, then the lesion probably is malignant. For example, you see some of these nuclei are smudged. Their chromatin is not, seen as well as it is seen in the other nuclei. So smudging of chromatin and isonucleosis, there will be a lot of size difference. The average size of the nuclei is, let's say, 1x. Then some of these larger nuclei may be 4 or 5 times the average size of the rest of the nuclei. So this kind of marked nucleosis and isonucleosis is suggestive of an atypical apocrine lesion or DCIS. And certainly the presence of necrosis would point to DCIS kind of lesions. In my experience, while these kind of features, including the presence of mitosis as seen here, So this is another feature that Rosen said that when it comes to apocrine lesions, the presence of mitotic figures and atypical nucleolar kind of features is suggestive of DCIS. So in my experience, all these morphologic features are helpful, but again, you cannot be dogmatic about anything. This is what I have learned, because it seems to me, as seen in these illustrations, that this is somewhat of an innate feature of apocrine cells to have some degree of anisonucleosis. Even in a benign cyst, sometimes you may see that some nuclei tend to be larger, and occasionally you may see actually a mitotic figure even in a benign cyst. So while all those features that Rosen pointed out are certainly of help in difficult apocrine lesion, the lesson to be learned is that you should never be dogmatic about anything in life. Now, sometimes apocrine changes may happen actually in LCIS. So when you see something apocrine, it's not automatically ductal, okay? Now this is obviously malignant, right? So this is not DCIS, this is apocrine LCIS. And the way, although this looks very worrisome and concerning for DCIS, as you will see, these cells are discohesive. They are falling apart. They are not like tightly arranged, cemented to one another. So this kind of falling apart is more a feature of lobular proliferation than that of ductal. And the way that you can resolve this is actually by doing stains. So here is an ecadherin stain which shows absence of ecadherin in these neoplastic cells. If this was a focus of DCIS, then the ecadherin stain would have shown you very strong membranous staining of individual neoplastic cells. So here, as you can see, these neoplastic cells that are infiltrating the duct are negative, but the resident ductal cells are staining with ecadherin. So there's a nice inbuilt internal control for this particular stain. So as I told you, that the use of immunohistochemistry is valuable in resolving difficult problems when it comes to ductal proliferations. Your initial starting point has to be morphologic, and you should be guided by morphology in what kinds of stains you order. Now, admittedly, uh, based on your experience, you are likely or unlikely to order the correct stains, and we all learn by mistakes. So there is nothing to be feeling ashamed of. Even after 40 years in practice, even today I make mistakes and I learn from them. Now, this brings us to the important question. Why is all this fuss about why do we need to make this distinction? Correct distinction within this spectrum of ductal proliferation. Now, obviously, the treatment is different, right? If this is UDH, the patient doesn't need any excision unless there are some imaging characteristics that make the lesion suspicious, and the surgeon may then decide to remove that area that is concerning on imaging. And then on the final analysis, a more accurate diagnosis is made. But if the imaging findings are not that worrisome, then the diagnosis of UDH will not lead to any excision. ADH, on the other hand, on a core biopsy, will lead to excision. And if on excision, the diagnosis remains ADH, then there will be only increased surveillance. Perhaps, these patients may be offered hormonal treatment, and some of the patients may even refuse to take that. And there is no need to go back If ADH is at margins, at least in the United States, surgeons don't go back and remove more tissue if foci of ADH are present on the margins of the lumpectomy specimen. On the other hand, DCIS, a diagnosis of DCIS on core biopsy will not only lead to excision, but certainly most of these patients will be encouraged to have hormonal treatment, especially for low-grade lesions, and if they are ER positive. And many of these patients will also be offered radiotherapy to reduce their risk for recurrence, because the risk for recurrence is reduced by half across the board when radiotherapy is given. And in addition to that, if the surgical margins are close in a lumpectomy specimen, in cases of DCIS, then more tissue is removed by a surgeon to ensure that pretty much all of the DCIS has been taken out, and that at least there are no macroscopic or sizable foci of DCIS remaining in the breast. Sometimes, ADH diagnosis on excision will be converted to DCIS, and in those cases, this approach will follow. So therefore, it's very important to make a correct diagnosis of these lesions on a core biopsy specimen. Now, I just want to end this discussion of intraductal proliferation with this comment that most of the times the diagnosis is straightforward. It may occasionally be difficult, and there may be actually challenging cases which even for an experienced pathologist may be difficult to resolve. In such cases, often immunohistochemistry is used, but I think you have to do your due diligence before you even begin to attempt a diagnosis. And there is absolutely nothing wrong in getting help from your colleagues. Go to more and more people, especially in the beginning of your career, because ultimately we are here to help a patient and to help our clinical colleagues to manage a problem appropriately. Let's move on to the next case. And this is from a 45-year-old in a stereotactic biopsy was done for calcifications. So here we see now these cystically distended spaces, right? Many of which are calcified. There are intraluminal calcifications. And this is sort of a very flat kind of appearance, which is targeted by the radiologist. Flat cystic spaces. And these are lined by somewhat atypical appearing cells, hyperchromatic cells with snouts on their luminal borders, calcifications in the lumen. The nuclei look somewhat hyperchromatic. Higher power. Some of these now begin to show nucleoli. So very low grade kind of atypia present in these ductal lining. So diagnosis here is flat epithelial atypia or columnar cell change with atypia. And the story of flat epithelial atypia began in the late 90s when Dr. Schnitt at Harvard, he looked at a large cohort of nurses who had undergone core biopsies. Now, these patients had undergone core biopsies several years ago when mammography-guided core biopsies began in the United States. So this began after maybe in the early 90s, because in the 80s, radiologists were just doing mammographies to look at breast. Guided biopsies were not yet happening. So, but anyway, so in this large cohort of patients, Dr. Schnitt was, he was puzzled by this kind of changes in breast biopsy, because you have to remember that there was no reason for pathologists to encounter these kinds of or pay any attention to these kinds of changes in mastectomy specimens or lumpectomy specimens, because those were pretty much done for either DCIS, palpable DCIS, or palpable or obvious invasive carcinomas detected on mammographies, right? So nobody paid attention to this, but Dr. Schnitt started paying attention because this was some kind of a theme emerging in his cohort of patients. So when he looked closer, he found that sometimes these cystics, kind of spaces were lined by hyperchromatic nuclei. And they looked something like this. And in fact, sometimes this lining actually was multi-layered. So hyperplasia already began, and these are very uniform. So these are highly atypical cells. These are uniform and now hyperplastic. So he coined the term flat epithelial atypia for this kind of change. Now, the other thing that he recognized is that sometimes, either in the biopsy or in subsequent excision, this kind of changes of FEA were associated with more progressed type of atypical changes, either DCIS or ADH. In fact, in rare instances, these changes of FEA were also associated with low-grade invasive carcinoma, like tubular carcinoma, as is seen in this. So these are these angulated atypical ductal luminal elements which are infiltrating the stroma. And this is a small focus of tubular carcinoma. So he decided that, such patients in whom you see FEA, because of their association sometimes with higher grade or more advanced lesions, they should undergo lumpectomy, at least lumpectomy. And there was a whole slew of literature after Schnitt's initial studies, which led to this rule of having excisions. And we'll look at some of that literature in a minute. But before that, I want to come to this question that just like our, question that we raised when we were deciding whether something is ADH or DCIS and things like that, this question of ATPI is problematic again because of differing thresholds between pathologists. So for a pathologist, something like this may look highly atypical. Somebody else may say, no, it's not atypical. Somebody who is working close to Schnitt may call something like this as FEA. Somebody who is working 3,000 miles away from Schnitt may call the same exact thing as benign. So this is the reality of morphology, unfortunately. So what is the solution? There is no real solution really, because these changes are part of a spectrum, right? And it is extremely difficult to draw a line, an artificial line, as it were, that divides atypia versus no atypia. It's like you have to train your eyes to recognize something in a replicative way to consistently make an accurate diagnosis, and that unfortunately never happens. And certainly it will never happen when two observers are involved. And therefore, as a way out, and because there are implications to that diagnosis, peer consultation and consensus is important. And this is the only substitute that we have at this time. Now, given the slow natural history of FEA, unless the risk is perceived to be high, such a diagnosis, at least now in New York, at Memorial Hospital in particular, does not result in excisional surgery. The surgeons and oncologists are happy to just follow these patients closely to see if something untoward happens. And then at that point, because the progression is so slow that even if there is progression, the next step might be ADH or perhaps low-grade DCIS. So not much harm is done by carrying out surgery in the first instance. Now, the upgrade rates of FEA in published literature are quite variable, as you can see. There are studies where the upgrade rates was 0%. And then there were studies where the upgrade rate was as high as 15%. So in the early studies done by Schnitt and others, the upgrade rates were on the higher end, and that led to the recommendation of excision. But in later years, and certainly a study done by one of my colleagues recently showed only an upgrade rate of 5%. So, we are quite happy to let these cases be followed or observed, and only intervene surgically at a later time if necessary. So that is where the state of the art lies in terms of FEA. Also, interestingly, although, the old studies, when it came to ADH and all, the ADH, presence of ADH was an independent risk factor for subsequent development of invasive carcinoma in breasts. FEA apparently, based at least on this large cohort studied by Mayo Clinic, FEA is not an independent risk factor for breast cancer. So if there is FEA alone, these patients are not necessarily going to be at risk to develop breast carcinoma. So that again supports this notion that perhaps there is no need to intervene surgically in all cases of FEA. But if there is some ADH, even minimal ADH, then I think at this time surgery is recommended. Okay, I think we are pressed for time. I don't know if we have more time. I think I have some more time to do this important case. And at that time, I will stop and invite questions. So this is from a 21-year-old female. An ultrasound guided biopsy was done. So this is a young female, right? So remember, with these lesions, you have to pay attention to every piece of information. So this young female had this core biopsy, which shows somewhat of a fibroepithelial kind of lesion where there is stroma and also ductal elements. So there is a combination of both stromal component as well as ductal elements. And then the edges of this particular lesional change, there is like a circumscribed face to it, right? So there are circumscribed edges. So this looks like a circumscribed lesion, and then you have to go back and look at what the radiologist saw. Was it like an oval lesion? Was it parallel to the horizontal axis? How big it was? How fairly representative this biopsy material is of that particular lesion? Because if the radiologist saw something was only like a 1 centimeter or 1.5, this would be a fair representation of that lesion. You do not expect to see anything very different from what you are seeing here already. On the other hand, if this was from a 70-year-old female who had a 5 centimeter lesion, you would have a totally different approach to this type of biopsy specimen. And we will talk a little bit about that as we move along this particular case. So again, on higher power, this look quite bland. The stromal cells, they are spindly or fusiform, and the ductal element themselves are unremarkable. Even at higher power, totally bland spindle cells, no mitotic activity at least visible in this field. Also, the ductal epithelium looks very benign. So and also we saw that wherever there was an edge to the lesion in the core, it was circumscribed. So based on all this, and having satisfied that this is a young person and the lesion was only measuring about no greater than 2 centimeters or so, And, the biopsy material was fairly representative of the lesion itself, you feel comfortable to make a diagnosis of fibroadenoma. Now, when we talk about fibroepithelial lesion, while fibroadenoma is the most common entity, once in a while you may see Phyllodes tumor, which may look architecturally similar, but this is a very different tumor with a different biology. So we are called upon to make that distinction on a biopsy specimen. So just to recapitulate, fibroadenomas are well circumscribed. There is nice distribution, uniform distribution of the ductal element. There is no, unequal distribution, symmetric everywhere, equal spacing between the stroma and the ductal elements. That's what you want to see in a fibroadenoma. And also the stroma is very low grade, not doing much. This is ideally what you would want to see in a fibroadenoma, almost like a lobule, the texture, something similar to a lobule. So symmetric distribution, uniform stroma throughout, well circumscribed border, rare or absent stromal mitosis, and obviously no stromal expansion and overgrowth. So this would describe very nicely the morphology of a fibroadenoma. Sometimes in very young patients, the lesion may be more cellular. They may be rapidly growing. You may see mitotic activity, and occasionally the lesion may actually grow to large size because they are actively growing. And although they are generally solitary, they can be multiple. So again, the age is very important. So when the patient is young and you say something cellular, there is no need to worry too much. It could simply be juvenile fibroadenoma, and you would then go back to the imaging finding to find out what exactly is going on and what the clinical impression is. So here is an example of a juvenile fibroadenoma in a core biopsy. So again, the stroma looks somewhat denser. So it is probably because it is more cellular. But when you look at the gross appearance of these lesions, they are well circumscribed, or very nice oval with lobated or lobulated kind of appearance on excision. As I said, they tend to be sometimes large, so size alone should not worry you too much. What is important to recognize is that these lesions, although large, will show the picture of a fibroadenoma. Uniform distribution, no overgrowth, no expansion, and so on. And on higher power, although you see mitotic activity, the cells themselves are not particularly atypical. So very bland cytology. So given the summation of picture, the clinical young age, circumscribed lesions on imaging, oval, parallel to the horizontal axis, bland cytology, and all features pointing to fibroadenoma, you would arrive at a diagnosis of a juvenile fibroadenoma. Phyllodes tumor is a different animal. This is decidedly an uncommon lesion. Only about 2.5% of all fibroepithelial lesions are Phyllodes tumor, as published in this paper by Stout many years ago, and things haven't changed ever since. So this is still a rare entity. So we have to remember that Phyllodes tumor is not the rule. When you see a fibroepithelial lesion on, it's probably going to be a fibroadenoma. So you begin with that presumption before you call something as a Phyllodes tumor on core biopsy. Now, most of these are benign. Initially, this lesion was described in 1828, and he considered it to be a benign lesion. This is a German pathologist who described this in 1828. Now, the fact that this is more likely to be benign, Phyllodes tumor is more likely to be benign, is also highlighted by the fact that although this lesion was first described in 1828, the first metastatic Phyllodes tumor was only reported after 100 years. So obviously, if it had been very common, then you would have seen earlier descriptions of malignant Phyllodes tumor. Now, some of the early literature on this topic is confusing. So if you read the older literature, you will be confused about this entity and the prognosis and so on, because early workers actually use different terms to describe this one same entity. And in fact, as many as 62 terms have been used to describe this same lesion, Phyllodes tumor, which we now call as Phyllodes tumor. So here is a typical example of Phyllodes tumor. It's called Phyllodes because it throws this finger-like or grape-like appearance into this cystic kind of spaces. So you have this, projecting into cystic spaces, these fronds of papillary kind of projections. But you will have highly cellular stroma encircling these ducts. The cellularity will almost always be higher than that seen in the fibroadenoma. Again, you will see quite cellular. The atypia can be variable, low to somewhat marked depending on the grade of the lesion. You will often see mitotic figures, so highly cellular stroma with frequently seen mitotic figures. And also, the appearance will be quite heterogeneous in contrast to fibroadenoma. As you can see that the distribution of ductal elements versus the stroma is very different in different areas, right? So here you have larger areas of stromal expansion within this same lesion in contrast to what is happening in some other areas. So heterogeneity is an important feature that distinguishes fibroadenoma from Phyllodes tumor. And in fact, you may see areas is indistinguishable from a fibroadenoma within a Phyllodes tumor. So heterogeneous appearance, increased stromal cellularity, stromal expansion, stromal overgrowth, no epithelial elements within your low power field or 4x eyepiece to give a total magnification of 48. That is how we define presence of stromal overgrowth. Varying degrees of cytologic atypia, presence of mitotic activity and leaf-like growth pattern and infiltrative borders. So these encapsulated the features of Phyllodes tumor in contrast to what we saw in the fibroadenoma. Now the recurrent questions when it comes to these lesions is, of course, is this a fibroadenoma or a Phyllodes tumor on a needle biopsy? Now this is an important question because in general, if you make a diagnosis of fibroadenoma on a core biopsy, unless the patient is worried about it or the lesion has grown rapidly on a short term, excision will not follow for a diagnosis of fibroadenoma. But if a diagnosis of Phyllodes tumor is made on a needle biopsy, then regardless of anything else, a surgical excision will follow. And then, of course, the other important question is, once you decide something is Phyllodes tumor on an excision specimen, is it a benign Phyllodes tumor or is it a malignant Phyllodes tumor? Obviously, a benign Phyllodes tumor is almost like a fibroadenoma in terms of its natural history, because nothing bad is going to happen to that patient. All you need to worry about is there going to be recurrence at some stage? And if there is a recurrence, all you need to do is just go back and excise in a limited way that recurrent lesion. On the other hand, a malignant Phyllodes tumor obviously portends a worse prognosis because these are the lesions which are capable of metastasizing to other organs and eventually, unfortunately, leading to the death of a patient. So now we come to this question: is it possible to distinguish on a core biopsy fibroadenoma from a Phyllodes tumor? Because they are generically similar, right? They are both fibroepithelial in a way. Both will show ductal and stromal elements. And a core biopsy gives you a limited picture, but we are called upon to make that distinction in a core biopsy specimen. So that is where the problem arises. So is there someone who can guide us on this? So here is a classic example of a fibroadenoma. The stroma is not doing anything, it's hyalinized. So if you see such a picture, you have looked at the imaging and the other clinical findings and all, you will confidently make a diagnosis of fibroadenoma. Unfortunately, these days, with so much imaging going on, this kind of picture of a fibroadenoma exists only in our dreams, because the lesions that the radiologists are now targeting are early. They are early in their life history, and therefore they are more cellular and growing. And they tend to be something like this. They're quite cellular, and then you are now called upon, oh, am I dealing with a fibroadenoma or not? And therefore they become challenging. So one thing that you can always do if you are not sure is to say this is a cellular fibroepithelial lesion, and the differential diagnosis is between a Phyllodes tumor and a fibroadenoma, and clinical and radiological correlation is suggested. And you can also say excision recommended for definitive diagnosis. Now, this kind of excision recommended for may not really be liked by the patient or even by the surgeon. They want you to be definitive, right? I mean, the surgeon always wants a definitive diagnosis. They want everything to be measured as either it is right or wrong. Like it is a binary kind of thing they want us to do. They don't want this dilly-dally kind of, that in their minds, they will lose, your credibility will be lost to them. So again, if you do this kind of approach very often, while this is a reasonable way of addressing the problem, if you do this often, the next that is going to happen is you will get an email from the surgeon asking you, don't we ever see the good old fibroadenoma anymore? Because that surgeon has probably used to see the diagnosis of fibroadenoma on core biopsies. And now you hear he has a breed of pathologists who are not that definitive on core biopsy. So that is the reality of our existence today. So how do we get out of this? So here is a 25-year-old female with a 1.6 centimeter breast mass. Now this looks kind of a little bit cellular here, and now I'm feeling uncomfortable. The patient is young, but the cellularity bothers me. And I'm saying, okay, this could be this could be that, and then the excision follows. And then of course the excision is well circumscribed lesion, very uniform. And then whoever looks at the excision will call it a fibroadenoma. And so the point I was making is that if for these kinds of lesion, if you always say that your differential is between this and that, and then always the diagnosis on excision is fibroadenoma, then the surgeon will lose your confidence. Now, unfortunately, fibroadenomas can look very different. And that is part of the problem, which I don't think that the surgeons appreciate. They don't know what we are dealing with. So sometimes, fibroadenoma can have this kind of atypical stromal cells. The epithelial elements may look different. They may look like adenosis. And now this is a very complex lesion architecturally, and you are in some kind of a spot. So you end up making that kind of, differential diagnosis kind of diagnosis. And then finally, it turns out that this is a complex fibroadenoma with sclerosing adenosis within it. Now, another example where, this looks very different. Like it's not a good biopsy to begin with, In spite of the lesion probably being big, the radiologist has decided to send a skimpy biopsy. Now, you have no control over the radiologist. And there is no way a surgeon is going to know what you are dealing with, right? So now you have here a small fragment of tissue with some stromal elements, a kind of not a picture that I see typically in a fibroadenoma. And then on top of that, there is something like a papilloma growing here. So what am I going to do with it? So I will end up with my usual approach, giving a differential diagnosis, and then the excision follows. And then finally, this is a nice circumscribed lesion with a different type of fibroadenoma kind of appearance, with some. So fibroadenomas can be sometimes complex, but they are still fibroadenomas. And that is difficult for us to recognize on a limited core biopsy sample. But it's important to educate ourselves from these kinds of illustrations so that we can keep our mind open and we can enter into some sort of an intelligent discussion with the surgeon and the radiologist, and perhaps with more experience, allow for a more conservative approach, which will also be quite comforting to the patient. So are there criteria, morphologic criteria that allow distinction between fibroadenoma and Phyllodes tumor on a needle core biopsy? Now, obviously, this question has consumed the minds of a generation of pathologists, right? So it's not surprising that there is considerable literature on this subject. The question is how useful these findings are. I will show you only one study. This came from Johns Hopkins a few years ago. And in this study, they concluded what the significant histologic features are to distinguish, to differentiate between a cellular fibroadenoma and a Phyllodes tumor on a core biopsy. So these authors found that if you see mitosis in 10 high power fields on a core biopsy, if there is overgrowth so the stromal elements are really prominent, if there is increased cellularity, if there is fragmentation. When they say fragmentation, what they mean is that one or both ends of the fragment of tissue is lined by epithelial element. So if you see that kind of fragmentation, if there is adipose tissue infiltration by stromal cells, if there is heterogeneity, and if there is subepithelial condensation of stromal elements, and if there is nuclear pleomorphism, if these features are present, if one or more of these features are present, then perhaps you are dealing with a Phyllodes tumor on a core biopsy. And what the authors, so this is just to show you some of those features, like a cellular kind of stromas, increased cellularity. So what these authors concluded is that if you have three or more mitosis in 10 high power, or a total of 3 or more of these histologic features, then the lesion on the core biopsy is probably a Phyllodes tumor. So such studies are useful. Again, I would make the point that I first made, never be dogmatic about anything, but learn from these studies that others have done and try to apply these to your own specimens. Of course, you have to be well, informed about your patient's details. I think there is no substitution to that. So for example, if you see readily mitotic figures in your core biopsy, then it probably is not a fibroadenoma unless it's an example of a juvenile fibroadenoma. If you see subepithelial condensation, as shown here, that is unusual for a fibroadenoma. It's a pointer to a possible Phyllodes tumor. Infiltrative borders, unlike circumscribed border, is a pointer to a Phyllodes tumor. So here the stromal elements are infiltrating the fat at the edges, at the interface of the lesion and the reactive stroma. Now you have to be mindful that sometimes what looks like infiltration may not actually be infiltrative. Actually, pseudoangiometastromal hyperplasia will often show you this picture. So you have to make up your mind whether it is a fibroepithelial lesion or not. And that may require some experience and understanding, Otherwise, you may end up calling something as Phyllodes tumor when it's not even a fibroepithelial lesion. So this is fragmentation. So a fragment of tissue with cellular stroma, and one end of the fragment or both the ends of the fragment are lined by epithelium. And this is not difficult to understand why this may happen in Phyllodes, because we saw, right, that in the Phyllodes tumor, there are these, finger-like projections. So the grape-like appearance. So when the biopsy needle picks something up like this is what you are going to see. In a fibroadenoma, that's not likely to happen because there is stroma, and when the biopsy is done, you will only get stromal elements at both ends of the fragment. So here is just to show you a fibroadenoma because there is no cystification. You will not see this kind of lining. So here is an example on a middle core biopsy. This is fragmentation. You are seeing so this is probably going to be a Phyllodes tumor. So it was a benign Phyllodes tumor on excision. So here we are seeing some fragmentation, but this was a fibroadenoma. This kind of fragments do not have any epithelial elements on top. Okay. So I think while those morphologic features are important and we should, look at those when we look at our core biopsies, the other important factors to consider are, of course, the age, right? So if it is a young patient, probably it's going to be a fibroadenoma. If it is an older patient, like if it's a 70-year-old person and you are seeing a cellular kind of a lesion, I would, not make a diagnosis of fibroadenoma. I think it's better in that case because in a 70-year-old, you don't want to see a cellular growing lesion. You would want that thing to be excised regardless. So age is important. Size of the lesion. The size is important because it tells you how representative the biopsy is of the lesion. If it's only a 1 centimeter lesion and the radiologist has removed 5 cassettes worth of tissue, the radiologist has probably cored out the entire lesion, then there is probably not much more to be seen anyway. And if it looks benign, it's probably a fibroadenoma. On the other hand, if on imaging it says 5 centimeter lesion and you have like a half or a 5 millimeter worth of tissue, then that may not be representative of the entire thing. And you don't want a fibroadenoma 5 centimeters in size to lurk in anyone's breast. You want that thing to be out. So size is important. Also, the clinical history. Is there history of prior fibroepithelial lesion? Because if there is a history of Phyllodes tumor, and now you have something that looks like a fibroepithelial lesion, it's better to have it excised, even if it looks benign, because this may be a recurrent thing, for all you know, or it may be a new lesion, and it's better that it is excised. If the lesion is increasing also, like in 6 months or a year, the lesion has doubled in size, then I think it's fair to get it excised. Fibroadenoma generally will remain static. They tend not to grow after maturing. They will just stay stabilized. And even if they grow, they will grow very slowly. Now, when the other thing when we talk about the size is, of course, what I already told you is you have to ask yourself this important question: is the biopsy a fair representation of the? And then lastly, of course, and the most important is the imaging finding. Always talk to the radiologist, if possible, what his or her impression is about this lesion. Because, if you work in isolation, then, that is a recipe for making errors. Now I'll show you a couple of cases before I end this discussion of how these, biopsy encounters can lead to pitfalls. So this was an older patient in which this core biopsy was seen. It looks kind of cellular, but there seems to be nice distribution of the ductal element. Now the stromal cells in retrospect do look somewhat atypical, but no mitotic figures were seen. And this, of course, the ductal elements also did not look anything abnormal. So it looks maybe something like a juvenile fibroadenoma. And therefore, a diagnosis of cellular fibroadenoma was rendered. Now, what was wrong here? First of all, whoever saw this biopsy in the beginning did not realize that the lesion came from a 70-year-old woman. And the lesion was large to begin with. Now, this diagnosis was rendered at an outside institution. And when the patient came to us with the biopsy, we did not have much of a problem because when the patient came, the lesion had to be excised actually. And the reason why the lesion had to be excised was that this was a nasty lesion. It had grown enormously over time. And so much so that the removal of the lesion also required sacrifice of the skin on top. This was only 4 months after the biopsy. Not only that, as you can see, there's no epithelial element in this. This is growing like a sarcoma and it's infiltrating into the fat adjacent to. So this is a nasty lesion. No, it does not look anything like what it looked in the biopsy. There were areas of necrosis. And then as you moved to the periphery of this lesion, you started seeing this subepithelial condensation. But even here, the periductal stromal proliferating cells are very atypical. So even with this kind of, if this is what was seen in the biopsy, a diagnosis of fibroadenoma would never have been made. But as you went further to the periphery of this lesion, you started seeing a blander type of appearance, right? So there is subepithelial condensation, but it does not look as atypical as it looks here. And as you moved even further to the periphery, you saw that there was like this tough kind of fibrotic stroma capsule to this lesion, and within which were embedded these ducts, something that we saw on the biopsy, right? So what happened here is probably the radiologist, given the size of the lesion, managed only to get the periphery of the lesion, which was not really representative of the interior of the lesion, because if the needle had represented these areas of the lesion, the picture would have been very different. So the error happened here because the pathologist did not ask this question, how big this lesion is and how old this patient is. Because if this was the question that was asked, he would have suspected that perhaps the thing that I am seeing in the biopsy may not be representative of the entire lesion and would have asked for another biopsy. And this is one of the common pitfalls when it comes to malignant Phyllodes tumor in core biopsy specimen, because what happens is that the core of the lesion, which may be nasty looking and high-grade sarcoma-like, these lesions sometimes tend to push the tissue at the periphery into some kind of a thick capsule. And the needle biopsy may just bounce off this capsule, and will give you an unrepresentative sample. So although the heart of the lesion may be something like this, which would be like a pleomorphic sarcoma, the periphery of it may begin to look something like this, So here you have an immediate transition from the highly malignant looking areas to now something, not as bad looking, and perhaps looking even benign, because only the benign portions were sampled. So with the very periphery, you may see something like this, So it's really unfortunate that the biopsy may not represent the real lesion. And ultimately, it's the responsibility of the pathologist, because he is the one who got the tissue and he has to ask all the right questions before rendering a diagnosis. Now, in some cases, it may truly be difficult to predict the nature of the lesion based on a biopsy sample. So you may do everything right, but those types of cases are rare. So here is a 21-year-old, so it's a young patient, right, with a 14 millimeter breast mass. And there were cores of tissue, which appear to be fairly representative. And this looks more like like a fibroadenoma with uniform distribution of epithelium and stroma. It almost looks like a tubular adenoma. There were some areas which look, oh, could this be Phyllodes tumor? But this is a young patient, there is circumscribed edge, and it's a relatively small lesion. And so, you might think that, okay, this is a fibroadenoma, and you may render a diagnosis of fibroadenoma. Now, unfortunately, such a lesion, this particular case, 2.5 years later, the mass grew actually to more than 3 times the size at initial presentation. And now, although the core biopsy looks something like this, and there were probably some areas similar to that in the now grown lesion, there were areas which look very different. So these are stromal expansion or even overgrowth. And then there are areas of Phyllodes tumor, like all these grape-like, finger-like things projecting into these cystic spaces, So this is now an entirely a different looking lesion. So this is probably, there were minute areas of Phyllodes tumor or malignant Phyllodes tumor in that biopsy sample, which were not seen in the biopsy sample, but in 2.5 years, now they are showing their true face. And this is now already a highly malignant lesion, right? So in a 2.5 years time, what initially looked like a fibroadenoma in a core biopsy, and any reasonable pathologist would have come to that conclusion, was in fact lurking underneath that was something that grew into a highly malignant lesion 2.5 years later. So how do you get around this problem? I think there may be very little that we can do about it. Only close follow-up. Hopefully the patient had been followed closely, and that would have led to an earlier capture. Now, this is another case where we saw this thing somewhat recently, some 6 to 8 months ago. This was again a young patient. So it's like, this looks fairly bland, right? And although there is some expansion, overgrowth of the stroma, they look pretty bland. So we didn't call this fibroadenoma, but we called it fibroepithelial. So with a diagnosis of fibroepithelial lesion at Memorial Hospital, generally a surgeon, the radiologist will refer such a patient to a surgeon for excision. but perhaps, I don't know all the details, but maybe the patient was not inclined, and therefore this immediately did not lead to excision, although it should have led to an excision. But what happened is that after 6 months of this initial presentation, the lesion grew remarkably. And then another biopsy was done. And this doesn't look anything like what we saw in this biopsy, right? So this is now, obviously you don't need any marks to suggest that this is a malignant lesion, right? So this is a malignant Phyllodes tumor on a core biopsy. So these kinds of things happen. So we have to learn from these cases, what is the scope and how these lesions can behave sometimes. So we have to keep a close watch. So while there is no need to be alarmed, because as I told you in the beginning, that malignant Phyllodes tumor is rare, right? Only about 2 to 3% of all fibroepithelial lesion is going to be a malignant Phyllodes tumor, much less a malignant Phyllodes tumor. I already shown you 2 or 3 illustrations where the outcomes have been very, very unfortunate. Now, this is not to alarm us. This is just so that we remain more informed and we do our due diligence when we handle these kinds of biopsy specimens. So this is just to show you higher power. You can readily see a lot of mitotic figures already in this, malignant lesion. So this patient had a mastectomy. Already the lesion had grown underneath the skin and the skin had to be removed. And there were some areas which resembled now a Phyllodes tumor because much of it was like a sarcoma. So this is a malignant. Okay, so why do mistakes happen when we deal with fibroepithelial lesion? Obviously, it is failure on our part to fully have the clinical and radiological findings. And I think there is no excuse for that. As I told you earlier, that any biopsy encounter that we have, once we have that encounter, we should go back into the patient record, find out the clinical details, radiological findings, history, any other biopsies, any family history, and so on, size of the lesion, and then decide how representative it is on the glass slide, and then move from there. In the absence of that, you are likely to make errors. And then the other problem is inherent, right? I mean, sometimes you cannot avoid mistake. Phyllodes tumor shows a wide spectrum of morphology with heterogeneity. And in those unfortunate cases, the sampling may lead you astray. Now, if you have done your due diligence, that sampling part of it may be taken care of. But when that is missing, then the inherent sampling problems will add to this, chances of making an error. And I think I will stop here because we are now on the dot of 90 minutes. And although I could keep talking on and on and on, just like Dr. Borges would do, I would like to spare you and let you do something more important. And I'm very happy to accept comments from our clinician, surgeon, friend, and also from the chairpersons. And I will end my slideshow here.
Thank you so much, sir. That was a very wonderful talk. Sir, Dr. Mandar has already left. I
Okay.
had asked Dr. Rahman to please speak a few words.
Okay, I will stop sharing.
At first, I'd like to thank Dr. Sumit to ask me to join in this seminar. And I am very much grateful And I congratulate Dr. Dilip Giri, had a superb deliberation in this uh, aspect regarding the benign lesions of the breast. And as he has discussed very keenly regarding the differences between the UDH, ADH, and DCIS, and how to differentiate and how to use immunohistochemistry. It's very beautiful. The discussion was very helpful for the residents, as well as he also discussed about the differences between the DCIS and LCIS and how ISC can help. He also discussed about the criteria regarding the size of the lesion, that is low-grade lesions where more than 2 darts or 2 millimeter. And he also mentioned that we have to be cautious regarding our diagnosis. Regarding calcification, we have to think and we have to consider the history and other deeper sections also necessary. These are also discussed. He also discussed about the papillary lesions, and Dr. Dilip has very beautifully described the apocrine lesions. It was very helpful. So it is also very important to know why we should learn the breast lesions, benign breast lesions, because we have to know the management also. And in UDH, there is no excision. In ADH, there is excision. But if it is very close to the margin, no need to re-excision, just surveillance is enough. But in case of DCIS, excision as well as radiotherapy, hormone treatment, and if the lesion is very close to margin, excision margin, so we have to re-excite it also. So these are very important. He also clearly discussed about the flat epithelial atypia and another very important issues which our residents repeatedly ask regarding the fibroadenoma and Phyllodes tumor. And in core biopsy, it is really sometimes very, very difficult to give a decision like fibroadenoma and Phyllodes, especially in the unexperienced pathologists. So all these are very carefully and elaborately discussed, and I am also delighted, enlightened. I am thanking again Dr. Dilip Giri for this deliberation. Thank you very much.
Thanks for the nice, kind comments. And I think, yeah, I think really, we have to be humble enough because ultimately the stakes are high. It's the patient, who is involved here, and we do not want to hurt a patient. At least, we should not hurt someone if we cannot help. So we have to do our due diligence and satisfy ourselves that we have done our best each and every time. There is no exception to that rule.
Yes. Thank you.
So there are a few questions in the chat box.
Yes.
Yeah. So the first one is, what is Roman bridge?
Sorry? Oh, Roman
What
bridge.
is Roman bridge? Yes.
Well, we have to go to Rome to see a Roman bridge, but I think, what they are alluding to is that, there would be like a bar of monomorphic proliferating cells along a duct wall, which then like shape like a bridge and then go to the other end, and there is like a tunnel underneath. So at the wall of the duct, you will see like a solid bar of cells with a lumen underneath, and these are like uniform looking cells. So that is what is, what describes a Roman bridge. And I think if you just Google Roman bridge. They will show you pictures of what an actual Roman bridge looks like. And perhaps the same Google images will show you cases of DCIS or ADH, which will also illustrate the Roman bridge kind of pattern.
So then, how to differentiate UDH from DCIS in the presence of necrosis?
Yeah, so I think you have to look at the rest of the morphology. So necrosis, while it is unusual in UDH, it can happen, as I said, especially in florid UDH. So when you get necrosis, in the cases of UDH, the cells that are proliferating will be, first of all, haphazard. They will look dissimilar. There will be overlapping of nuclei, and individual cells within that population will not show really, significant nuclear atypia. The nuclei will be vesicular with small nucleolus and so on. And you will see other features like streaming of the nuclei, and then, the fenestrations instead of punched out spaces. So I think these are the pointers towards a benign process. Now, if this is something that bothers you, then I think that you should actually, show it to others. That is, I think, one way of avoiding a mistake. Depending on your experience, you will probably be able to make a better judgment. So there is no like one rule of what exactly, is the difference between UDH and ADH. You have to have a constellation of things in your mind. But I think if you see a lot of overlapping of nuclei, different type of cells, populating the ductal space, fenestrations instead of punched out spaces, cytologic atypia is not really present, there aren't many mitotic figures, then I think it points to UDH. Now, in some of those instances, if immunostaining is available, then you can do stains like, ADH5 or CK5-6, and that should pretty much help you nail the diagnosis. And then, of course, if these stains are not available and you are still in doubt, you can show it to your colleagues. If still you are not happy, then I'm sure that there are experts around you who will be able to be more definitive on a case. That is how it works.
Yes, sir. So the next is importance of myoepithelial secretions in benign lesions.
Myoepithelial cells.
Secretions that they're saying. I don't know.
There is no secretion. There are myoepithelial cells that are present. So, duct epithelium is bilayered, right? There is one luminal epithelial cells, and then there is an outer layer, which is myoepithelial. So these myoepithelial cells, the demonstration of myoepithelial cells becomes important when you want to decide whether there is invasion or not. Because if it is a non-invasive process, then you will see myoepithelial cells around those proliferating foci. There is absence of myoepithelial layer around those kinds of malignant looking foci, then that is probably invasive carcinoma. Now, sometimes, using these myoepithelial stains, even in DCIS, you may not be able to demonstrate a myoepithelial layer. And that happens because there seems to be some interaction going on between the epithelial and myoepithelial cells. So probably the malignant cells in DCIS, they probably, first of all, they will push the myoepithelial cells, right? So they will become less when you think about it three-dimensionally. So let's say if in a normal duct per unit area, there were 10 myoepithelial cells. Now, if this unit area expands to 10 unit areas, right? The myoepithelial cells are not proliferating, right? Because they are benign. So now they have stretched into a 10 unit area. So there will be only 1/10 of the number of myoepithelial cells for that unit. So when you use a myoepithelial marker at a particular level that you are looking at three-dimensionally, there may be no demonstrable myoepithelial layer. So that may lead you into thinking that, oh my God, there is no myoepithelial layer, so is this malignant? No, you have to look for what looks like conventional invasion. So this is an entirely a different topic which could consume hours of our discussion. But I think the demonstration of myoepithelial layer is important when you are deciding whether something is in situ or invasive. Not so
Okay,
much
sir.
within the realm of benign ductal epithelial proliferations.
Yes, sir. Sir, the next is how to differentiate fibromatosis versus phyllodes.
Yeah, so I think that is a good question. Fibromatosis is a stromal lesion. Fibroepithelial lesions are, by definition, they will have both elements, epithelial and non-epithelial. Now, occasionally, fibromatosis, especially on a core biopsy, may pose a difficult problem because you may not be able to decide whether or not there are other epithelial or other areas which are more fibroepithelial. So in those cases, and you have to, of course, go to the imaging because it's possible that the fibromatosis, the imaging findings may be different. And secondly, the type of cells that are involved in fibromatosis, they are different morphologically, right? So you would have to go into the description of the cells involved in the spindly cells that are present in fibromatosis. So you will be looking for those kinds of cells. And if you still have some doubt, you can always do beta-catenin immunostain. So nuclear staining with beta-catenin will point to a diagnosis of fibromatosis. The cells within a fibroepithelial are almost always CD34 positive, but they will not show nuclear staining with beta-catenin. So, yeah, so these are some of the things that you can use to address this problem. Now, even if it's still not resolvable, then there are always these difficult cases which only an expert can really accurately diagnose. So we do encounter here cases of fibromatosis, which on core biopsies, but with this approach, we have been able to satisfactorily resolve the problem.
Right, sir. So the next question is regarding Roman bridge itself, that if it's present, can we straightforward call it an ADH?
Sorry, can you repeat?
Roman bridge, sir. If
Roman
we
bridge.
see Roman bridge, can we straightforward call it an ADH?
No, I don't think that Roman bridge alone, Roman bridge can be present also in DCIS, right? So it could be either ADH and DCIS, and that determination you will have to make based on how much of the atypical changes are present. Is it a lot, which would point towards low-grade DCIS? If it is very focal and minimal, then that would probably be ADH. Now, you would normally not expect to see Roman bridge kind of pattern in usual ductal hyperplasia. So if you are seeing Roman bridge, then you will probably see monomorphic cells. The rest of the picture will be more of a kind of a ADH or low-grade DCIS. So I don't think you can use the presence of Roman bridge to automatically say it is ADH. It could also be low-grade DCIS. But more importantly, you have to look at the extent and also at the uniformity and whether this is really a neoplastic proliferation. I think it's not a good idea to be dogmatic about one feature. So that is the wrong approach.
So the next is in vacuum-assisted biopsies and excisions, mostly the tissue is fragmented and the cells are scattered. So how to approach that?
Yeah, so I think this is inherent inherent problem, especially with fibroepithelial lesions. So you have to try to use those criteria that people have published, how to, address this question of fibroadenoma versus FEL on core biopsies. And then again, you look at the imaging and other features. Now, if it's a small lesion, looks benign, it's probably been totally cored out in a vacuum biopsy. So I hope this helps.
So someone has asked, can you recommend a book for breast lesions?
I mean, there are many books. You can always read Rosen's, breast pathology. Dr. Hoda is now the main author for Rosen's pathology. That is really a definitive tome on breast pathology. You can certainly read that. And there are a number of books on biopsies. Dr. Schnitt has published, Dr. Hoda himself has published on core biopsy interpretation of breast lesions. So, I mean, there's not one book that I would recommend. Any one of these books is good. That is a good starting point. But I think you only learn, unfortunately, you learn this art only with experience. So there is always a starting point and you build up on that. And as I said, even today, after 40 years, I still make mistakes. And I have to be humble enough to accept that I made a mistake.
Right. Sir, Dr. Rahman has already left. He had some family function.
Yes.
There are still a few questions which have already been answered in the presentation. So I'd like the students to please revisit the replay link for those questions. And sir, I think that will be all for today. Thank you so much, sir.
Thanks. It was really great being here and interacting with so many people. I do recognize that people who are attending this meeting, they are at different levels of their experience and expertise when it comes to breast pathology. And for some of them, this may be totally elementary and redundant. My apologies to those. Thanks for bearing with me. But I'm sure that there were some beginners who probably have learned some good lessons. Thank you.
Definitely, sir. There's a lot of praises for you in the chat box. I'll read a few. Thank you, sir, for such a wonderful session. You highlighted many practical points and inherent challenges. Someone else wrote, thank you for the excellent talk. Every point has a practical significance. Enjoyed your talk. Great inputs as always. There are many in the chat box.
Yeah. No,
Thank
we
you
don't
so
need
much.